This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon practicing in New York and New Jersey.
I'm Marina Kurian. I'm a general surgeon that does minimally invasive surgery, bariatric surgery, and actually also some medical weight loss in New York City.
Welcome to the show. This is our 10th episode, Marina. Can you believe it? Today we have two wonderful guests. Our first international guest, we have Dr. Ananta, who is the president of the British Indian Psychiatric Association, and Dr. Anupama Gotimukula, who is the president-elect of the American Association of Physicians of Indian Origin. And between Marina, myself, Ananta, and Anupama, this is our way of celebrating Indian Independence Day. So happy Indian Independence Day, Marina.
Right, because there was no parade. So all of you who missed the parade, which we always have in New York City, and in other parts of the country and certainly the world, this is it. You get us. No floats, no dancing, no music. No awesome street food,
wow. No amazing street food. Anupama is a pediatric anesthesiologist in San Antonio, Texas, and Ananta is a child and adolescent psychiatrist in the Midlands in the United Kingdom. So we're really looking forward to having them on. And please, as always, like and share and tag your friends who are interested in learning about medicine for children, learning about psychiatric and anesthetic issues, and learning about COVID, and just spending an hour with four pretty nice ladies.
Yeah, we are mostly nice.
We'll see. Well, we are surgeons.
We are, but we're going to get psychoanalyzed, and I'm sure the pediatric anesthesiologist will have a lot to say about us surgeons. So let's just see what's happening. But I think it is going to be a great show, to get two pediatric specialists on, and so that we can talk about the impact of what this quarantine pandemic has done for mental health in children, as well as some of the other issues related to COVID in children, because we're seeing some numbers in kids now and some new research that's coming out about that. And we're going to end up talking to them about some of that new research. But we should touch base on some of the stuff that we do every week and what's hot and in the news. And, New York State has been doing a pretty decent job of testing compared to, I think, some other parts of the country. And our positivity rate is a little bit under 1%, which when people first looked at coronavirus, they would wanted to say that, okay, this is where it should be. This is what we expect from H1N1 or the influenza. So this is sort of where we expect it to be. And that's what we're seeing. Do you want to go through some of the other numbers, Suju?
Sure. So this slide that we're showing right now shows that New York State is testing 72,000 people and only getting 640 positives. And that's what we really want. We want to be able to test the big denominator of people and see what the actual positivity rate is in our area. And that goes to school openings, which we're going to talk about in a bit. COVID is far from over, as you guys may know. The latest update is 21.5 million cases that have been reported around the world, with 13.4 million of those patients listed as recovered, and unfortunately, worldwide, 771,000 deaths from this disease. In the United States, we have 5.37 million reported cases, and we've had to date 169,000 deaths from COVID. In the United Kingdom, 31.7, 317,000 cases have been reported, and of those, 41,000 deaths. And in India, 2.53 million cases and 49,000 deaths. So I think, Marina, you and I have talked about different reporting, different testing. I think the slide that you showed earlier shows that if we are able to get more tests done, we can have a much more accurate assessment of where we are in terms of the amount that this disease is affecting us. And you know what, Marina, we still have to talk about masks. So maybe you can talk about South Carolina and masks.
Certainly. So South Carolina came on the news this past week because certain counties in South Carolina actually say they mandate masks. And so when they looked at the whole state, they found that coronavirus cases dropped almost 50% in parts of South Carolina, or the counties in South Carolina that had mask mandates compared to those without. So it's, I think, a worthwhile thing to do. We're doing it here in New York, and most everyone in New York is doing it. And of course, I love did we talk about this last week? I love the slide that came up and said that those gaiters that people wear when they're running and stuff, I totally bought into that. I'm like, oh, it's wicking away moisture. I 100% need that. And I bought a bunch of them. They are the worst, apparently. They are no good at all. It's worthless. Don't wear those as any kind of mask. And then at the same time, last week, I saw a tweet from, I believe he's a doctor, about how he ran 7-minute miles with his surgical mask on. And not the N95, but and I was like, first I read it, I'm like, you ran 7 minutes, that's great. It with the mask on. And then I was like, oh, he ran 7-minute miles, which are fast. I'm just going to admit right now that my mile is like an 11-minute mile. I think that some people might beat me speed walking. So I was super impressed. And obviously that's a lot of hard work. And he was doing it with a mask on for those people who feel like they're not getting enough oxygen. He's very, I think that was a great way of showing that you can do a lot with these masks on.
Yeah, so my mile is really fast. It's like 10 seconds because I do it in a car. So what can you do? So you can follow these 3 W's and these three other things that the government can do. So you can wear a mask, you can wash your hands, and you can watch your distance from people when you're indoors, particularly without a mask, but even with a mask. What government and organizations can do include testing, tracing, and isolation. So they can test enough people, when there's a positive person, they can trace their contacts, which is very complicated to do and requires a lot of buy-in from the community. And then they can isolate the positive person and their contacts to minimize the spread of disease. So we have some really good breaking news that just was announced yesterday. The United States Food and Drug Administration announced emergency test authorization to the Yale School of Public Health for something called Saliva Direct, which is developing a spit test for COVID. So this technique is proprietary, but the School of Public Health is actually open sourcing it, which means everybody can use it without paying a fee. And you eliminate the extra stuff that you need to do like a nasal swab or a nasopharyngeal swab and the reagent. So it's actually going to be a much faster and quicker test. My son is going back to college and he got this test in the mail. And he is apparently supposed to put this giant Q-tip into his nasopharynx, which is way back there, and send it along in a test tube. So he's going to do something. His mother's going to put it in his nasopharynx because I'm very comfortable in the nasopharynx. Most people would not. But if you could have a spit test where there's no exposure to the people administering the test and you can get some data, I think that really helps. I want to welcome Radhika Mahimthra, who's watching from Jersey City, Neil Parekh, who's watching from Virginia. So why don't we talk a little bit about schools opening, Marina?
I'm so excited, but I know that people are scared. I'm sending my kids to college. Their schools are opening. A lot of the classes are going to be online. I think that from a socialization standpoint and from kids already going through the quarantine process before, that I do think it's important. And I am very thankful that both my kids' institutions have great plans in place to deal and monitor. And of course, the kids get tested, and my children have been tested. They test negative. But I think that this is a great thing. Now, recently, and I think also this past week, Sanjay Gupta, who is the CNN chief medical advisor, he said he's not sending his kids to school. And the thing is, and I think Sujana and I discussed this before, is that where he lives, there's a much higher positivity rate than there is where, my kids are going to school, and also what we have in New York. Currently, because our positivity rate is so low, under 1%, as I mentioned earlier, New York City schools are going to open, and they're still figuring out, I guess, what the exact protocol is going to be, but they are going to open. And as I said before, I think it is important for the kids. We've mentioned that whole concept of summer slide, where the kids are not in school, and so therefore there's like a little bit of a educational slide backwards. And this not being in school and doing remote learning, I think, was a disaster overall for education, mainly because this is not the preferred format for teaching kids. So.
And, we did a whole show on schools reopening. We were very fortunate to have the president of the American Academy of Pediatrics, Dr. Sally Goza, the executive director of the National School Nursing Association, Donna Mazik, and top infectious disease expert, Dr. Heather Klaus from Temple University. So you guys can all go back and watch that. And we had so many questions that day that Marina and I actually just spent 25 minutes answering the questions to the best of our ability. And you can find that on our channels as well. And I hope you take a look at it. But now that we've covered all of this, Marina, let's meet our amazing guests.
That's right.
So, reminding everyone, we're live on Facebook, on Twitter, on YouTube, on scroll.in. Please like and tag and share with your friends. Let your friends know that we're talking to two amazing women physicians today. And Marina?
Yeah, Dr. Ananta Dave, welcome. She's a child psychiatrist who's president of BIPA, and then also Dr. Gotimukula, who is pediatric anesthesia and president-elect of the American Association of Physicians of Indian Origin. Welcome, you guys. Thanks so much for joining us on a Sunday morning, or actually afternoon for you, right, Ananta?
Yes, that's right. Afternoon in the UK, 4:15 almost. And I'm so delighted to be on the show. Thank you firstly for inviting me. It's so nice to make these connections across the border, and really important to understand the perspectives, in various countries of the world. And I was listening to the stats that you were sort of mentioning in various parts of the US, and also the conversations that you'll have been having about children going back to school, and how you make sure that people are following all the advice and guidance around the keeping the distance and the mask and the hand washing and the testing, tracing, isolation. So similar messages going on in the UK. So good to be part of the conversation. I think it's an excellent initiative that you all have started, and I understand today is the 10th episode. So really, very happy to be on the show, and thank you. And also an added bonus, I'm with Dr. Gotimukula, who also works with children and young people. So it's good to be there with you as well. So thank you for that.
Thank you, Ananta. Thank you, Sujana and Marina. It's a pleasure to be with you all today.
Yeah. Did you hear our comments, Anupama, about like surgeons and anesthesia? We always blame the anesthesiologist.
Excellent combination. Yes.
I believe in teamwork, so there's less blame, more sharing. Sharing is caring. So,
right.
Talk to us about Houston. About Texas, where you are, and in terms of what you're seeing at the hospital, if you're seeing a decrease, because I've heard from some of my colleagues that in Houston and in Dallas, that they're seeing a little bit less positivity and less not as sick patients right now.
Right. Yeah, there is a small decrease, but not yet to say that we are like New York, and we are still having significant number of cases, positive cases, but we have enough beds right now in the hospitals, ICUs, and also we are not short of beds, but as such, the decrease is very small. I wouldn't say it's still we are out of danger or anything. I wish we have numbers like New York. I wish we are like that. The whole country is like New York right now. That would be the best news to hear, but we are still not there yet. Yeah, and unfortunately, being a pediatric, in the pediatric anesthesia specialty, it's going a little, the children are increasing in numbers. Like we see more kids having COVID now, which is not good. I will show you the numbers when I get to the slides. Yeah.
So, we are seeing issues with COVID transmission in where people can't really isolate, so we're seeing a socioeconomic divide in COVID transmission where people can, in fact, isolate in single-person homes and where they can't. And I wonder, we had a really quite a terrible statistic come out from Kaiser Health News and The Guardian, and 922 healthcare workers have died of COVID-19. And the toll is obviously still rising, and this is despite doing our best with PPE. We were quite shocked in the United States, and I think we still are around the world, of the lack of access to proper PPE, which is personal protective equipment. But Ananta, you actually spoke a great deal about the impact of COVID-19 on what is referred to as BAME in the US, which is Black, Asian, and Minority Ethnic staff in mental health care. It's an acronym we don't really use in the United States. So it's Black, Asian, and Minority Ethnic. And I wonder if you can talk about that issue with us.
Yes. Thanks, Sujana. Yes, I mean, the acronym that we use, I think it's sort of come about so that it's easy to sort of use it as a phrase, but there are discussions going on as to what is a better phrase to use, because it homogenizes, a variety of groups of people who come from various parts of the world and various ethnicities. So I think it doesn't accurately capture everyone. But I think the important point is that very quickly on, we became aware when COVID struck that it was disproportionately affecting people from a Black, Asian, and minority ethnic background, both in terms of healthcare workers and also in the general population. So although the work that I did, and I was chair of the Task and Finish group at the Royal College of Psychiatrists in the UK, which is the professional body for psychiatrists, although we led on the work for mental health care staff, the principles and the general points that we recommended are applicable across a variety of healthcare settings. And subsequently, we had national guidance coming out from organizations like Public Health England, NHS providers, a British Medical Association. So a range of bodies also have come up with guidance. But essentially what we did is 2 pieces of work as part of the Task and Finish group. And we now have a work going forward, which is hopefully going to look at issues beyond COVID. So although COVID has amplified the inequalities and the problems we have, we want to make sure that the work that started now to address these inequalities is sustained beyond COVID, because we need to bring about long-term structural change if we are to address these inequalities and reduce them in the future. So the 2 pieces of work we did, one was something which would help us address the situation very quickly. So what we did is come up with guidance that I think you were just showing, which was about making sure that we were able to capture the risk that staff faced in healthcare settings very quickly in a structured, sensitive, and stratified manner, so that we would then be able to put in place some risk mitigation for those staff. And we were very clear in saying that we need to do it for 2 reasons. One is it's the right thing to do to protect people's lives and, protect staff. Also, if we know that there's a disproportionate impact on some groups, we need to address that. But very importantly, unless we look after the staff, we can't continue to provide the services that people need. So what we did is we said that firstly, there should be a risk assessment process, which should be a conversation between the employee, the staff member, and their line manager. In the case of medical staff, it would be clinical director or medical director. But in other healthcare staff, the line managers, so that we understand the risks that the employee faces in terms of ethnicity, gender, medical conditions, the role they do, the settings and the environment they work in, etc. And then there's a plan. And what we also said as part of that guidance is we said that organizations, that is in the UK, the vast majority of healthcare is provided by the NHS, which is publicly funded. So we said that in the NHS and in other healthcare settings, and even in social care settings, these are the things that organizations can do. So right from identifying this issue, that is the risk faced by BME staff as a risk to the whole organization. So right from that to looking at how you create safe spaces for staff to talk about their needs and issues, how to raise concerns safely, how to make sure that we've got aids for remote working, PPE, redeployment, etc. So an organizational approach and culture led by the board and looked at as a key quality and safety issue. So we made recommendations around that as the first guidance. And the second guidance was recommendations that we made to the Royal College of Psychiatrists, but it was intended to be more long-term. So addressing some of the structural issues around why are we in this situation where there's lack of representative leadership, lack of a full understanding of the issues. So we looked at how we could address training, supporting managers, looking at the equality, diversity issues, looking at how we promote talent in people from minority backgrounds. So we made a set of recommendations to the Royal College, which is again applicable across a range of settings. So these are the two pieces of work that I led on. Thank you.
Have you actually seen a difference yet? We had all these hashtags take off, right? So hashtag I look like a surgeon to sort of look at the distribution of minorities and as well as women in leadership, and how if Suju and I show up in a room, that we can be mistaken for everybody but the actual surgeon. So this came up, and what we're doing in different societies is actually trying to increase the representation and create like different mentorship programs to try and include minority representation, as well as representation of women. By the way, women being the majority, because it's 51% of the population, but a separate issue. So do you feel that a lot of your interventions have started a process? It's nice to say yes, so for the Royal College to be like, that's great, we're going to definitely do it, but what's actually been, do you see an implementation? Whereas I can say that some of our surgical societies, that there is actually a thrust to make changes, and changes have already started.
I think changes have been happening, but in a small scale. So I don't think it's been the kind of sustained significant improvement in representation that we would like to see. I mean, the NHS where I work, 77% of the staff is women, but the representative leadership, just talking from a gender perspective, is nowhere near the mark. The recommendations that we made to the college are very recent, but what I can say is that the changes, for example, the British Indian Psychiatric Association that I'm the president of, I'm the first woman president, and in the 25-year history, but it's a good step to see. The vice president this time is a woman, and we've got a good gender balance in our executive committee in the leadership of our organization. Similarly, in the NHS, I'm a medical director, and there are not many of us from a minority background and women at the senior leadership, board leadership level, but it's increasing very slowly. What we have in the UK, in England, is something called the Workforce Race Equality Standard. And that has been measuring over the last 5 years certain indicators. One of them is about looking at representative leadership in very senior positions. In the UK, we call them band 8 and above. And in medicine, they would be medical directors, board level, and very senior leadership. So that's shown a marginal increase over the last 4-5 years for which we have data. So it's still in single digits, though, at board level representation for women and for minority ethnic backgrounds. So there have been small gains. And I think what we are saying, COVID has given us a sense of urgency, and we need to make it much more widespread and consistent across the country and across the nation.
What we didn't say earlier is this was another leadership show, because we do have past president, a current president, president-elect, and two current presidents. So we're bookending the presidencies here. So thank you for all that.
So yes, thank you. And I think you're right. Until we measure it, until we show the data where there are discrepancies, we actually cannot help move the needle forward and help with representation. And I think we all understand that representation matters in all walks of life. I want to get back to being Indian and Indian expat. So about 60,000 Indian trained physicians practice in the United States, the United Kingdom, Canada, and Australia. And that's actually about 10% of the Indian physicians trained in India are all emigres. So India actually exports the most number of physicians. As of 2018, API, which used to be called the American Association of Physicians from India and is now called the American Association of Physicians of Indian Origin. And I thought that was a very smart move, because that includes people like me who are of Indian origin but were trained in the United States. So API says there are about 222,000 physicians of Indian origin in the US. We account for about 18% of all doctors in the US and a quarter of all the international medical graduates employed in the United States physician workforce. There are about 60,000 doctors of Indian origin working in the United Kingdom. So maybe Anupama, as president-elect of API, and maybe we'll talk about women in leadership at API, can you talk to us about why API was formed and what it's doing to enhance the experience of physicians of Indian origin and, of course, our patients? Because I think our physicians work in areas that are relatively underserved in medicine, and I think API represents physicians who really serve a vast population.
Right, Sujana. I agree with what you said. The physicians of Indian origin, as you said, we have about, as you said, more than 100,000. I don't know about 200,000, but at least more than 100,000 are physicians of Indian origin. And also 10% of medical schools have kids of Indian origin. And as per the statistics, they say that 1 in 7 patients is being managed by an Indian physician. So that's where we are. So we are every corner of the country. Mostly our physicians are in the rural setups. They serve the underserved areas under different visas like J1, H1, and so and so. So a lot of physicians are working in the rural areas. So we are the skeleton of this country giving the health care. So we are very proud being an Indian physician here. And to go back to the history of how AAPI was formed, in 1982, a bunch of physicians in Michigan, like when the early physicians of Indian origin, they moved here in the early 60s and 70s, right? So we had somewhat a racial discrimination. Those years, what I heard from those physicians who moved here in 60s, they said like they were put in, far away, not in the apartments where every other resident stayed. They were given a far away place to stay, and a lot of discrimination connection at the workplace as well. So that's how they came together and said, we need to have a voice for ourselves. So that's where we are. In 1982, 8 physicians or 10 physicians made this organization. And look at now, we are like, more than 100,000 here, but we have life members about 14,000 right now, and many more annual members. And we have different sections: young physician section, medical student, resident fellow section, and we have the members. So it's a growing organization. We are 38 years old now.
That's amazing. We look pretty good for 38 years old. I actually remember when API started, which of course meant that I remember from when I was, minus 10, right? Or something like that. But Anupama, you had actually provided us with some very cool slides on COVID and how it's affecting populations. And I think in particular with the children. And I wonder if you don't mind sharing a couple of those with us and giving us some idea of where your head is, because I know, obviously it's awful when anyone gets sick. It's particularly awful when children get sick. And then you, especially on the very frontest of the front lines, you're intubating children, you're being exposed to their coughing and their airway. Can you explain to our audience what kind of precautions you're taking, and then what kind of precautions they should be taking to be as safe as possible if they end up in the hospital?
Yeah, I will answer all the questions. Let me go over these few slides. And so I was looking at what exactly, where are we in the pediatric world? So I kind of got this information, which is very recent. And look at the numbers now. 179,000 children got positive from July 9th to August. So August 6th, this is like a month. A 90% increase in child cases over 4 weeks. That is really alarming and scary to us who work in the pediatric world, especially in this era where we are about to start the schools. And look at the testing. Children made up between 3 to 12% of total state tests, and 3.7 to 18% of children got tested positive. Let me go to the next slide.
And just, I'm going to remind everyone while we're changing slides, people are watching from all over. We have people checking in from California, from Bermuda, from Las Vegas. Thank you very much for watching. Please share and tag your friends who would be interested, because I think this material that's being presented today by both of our guests is outstanding.
So, Sujana, look at the hospitalizations and mortality in children. So if you look at those numbers, 0.5 to 5.3% are reported hospitalized. And look at the mortality, 0 to 0.4%. So it's really very low. So that way we are fine. Children are at low risk to have the disease. There are cases with multi-system disease, but very rare. So based on these, I think all the societies are gearing up to start the schools. So here, and being a pediatric anesthesiologist, so I know we do COVID cases. I work at Children's Hospital of San Antonio, and we have almost 10% admission rate with COVID right now. And almost we were 0 in June. In July, we started slowly having at least 1 case a day in the OR coming for different kinds of emergencies. The elective surgeries, we always test them 48 hours before, and then once they are negative, they come to the OR. If they're positive, they are postponed. But the emergencies we cannot avoid, so we have to do those, like appendectomies or tonsil bleeds or ENT abscesses and so and so. So those cases we have to do. So at least 1 case a day we are doing right now, which is sad. And last week we did 3 cases positive. So the way the numbers are increasing, it's kind of alarming us. So we do have all the protective equipment. So this is what we do when we have a specific room or set up for the COVID cases only, and we have the negative pressure room, and we have all the donning, doffing, everything done there, and so we have the masks. Like I have the N100 mask, and I wear two different masks on top of it, and a shield, and a bunny suit, like a white bunny suit, and the blue gown, and then shoe covers, and like I'm covered almost. So in spite of doing COVID positive, lucky none of my partners have become positive yet or anything. So that's good. Like the protective equipment is helping us to protect ourselves against getting exposed to these kids. And we have to work every day. We cannot sit at home because I did one COVID case. I can't go quarantine for 2 weeks, right? So we work every day. We check our temperatures, and we watch ourselves, and we quarantine at our homes as much as possible to protect other people at home. But unless we have symptoms, we are not supposed to quarantine because we are wearing all the protective equipment while we are in the OR. And we have to wear the mask all the time in the OR. So everyone is following strictly all the guidelines. So that way we are not, none of my staff or anyone got COVID from patients as of now. That's a good news.
So I want to shift gears a little bit to Ananta, and I'm sorry I have to read this because it's a lot of stats here. Okay, so the Morbidity and Mortality weekly report came out with sobering statistics, and they are that during late June here in the U.S., 40% of U.S. adults reported struggling with mental health or substance abuse, and that the rates were highest in the youngest groups, 18 to 24 and 25 to 44, who previously we thought, they're going to be the ones least likely to suffer serious COVID disease, but we're seeing some change in that as well. But it really stands out because what they're seeing is that one or more adverse behavioral health symptoms was seen in 75% and 52% of these younger groups, compared to 30% in the 45 to 60-year-olds and 50% in the over 65. So that the mental health struggles and or turning to whether it's alcohol or marijuana or other drugs was higher in the younger age group. So it's concerning, and it goes with a lot of the other literature that's been coming out talking about mental health and depression and other symptoms that are popping up all over the world. So you could maybe speak to what you're seeing in Britain, and then what also you think of some of these statistics.
Yes, thanks, Marina. I think you're right. There has been an increase in people seeking help for mental health problems in the UK as well. What we've seen is, there's although figures of around 25% of the population having mental health problems has been mentioned for a long time. If we look at specific age groups, we know that now we are seeing an increase in the number of young people seeking, so those who are presenting with mental health problems now, we are seeing more of younger people, that is, right from a school-going age up to the 18 to 25 bracket. We are seeing more young women coming forward, and we are seeing an increase in what we call substance abuse, both alcohol and substances presenting along with mental health problems. So either independently or along with their mental health problem. And I think when we are trying to look at, doing capacity modeling and demand, people are preparing for, say, almost a 20-30% rise in work or demand compared to what it was pre-COVID. And every age group or every group of the population has got specific reasons why, or specific issues which might make them more prone to either a worsening of their pre-existing mental health problems, which is what we've been seeing. So if there are people who've already had a mental health problem and are seeking treatment for it, that's worsened. We are also seeing many more new people than we would have seen normally come forward seeking help with mental health problems. And we are seeing a slight shift in the demographics, as I said, more young people, more female. And in those who are presenting, especially men, we are seeing more acute presentations. So, for example, people who are being assessed or detained under what we call the Mental Health Act, which is the formal legal mechanism we have for detaining people in hospitals if we feel that they need treatment. And the numbers of those are going up. And there are signals. Now, there is no established data, and it's really important to be clear about this. There is no established data saying that the number of suicides are increasing, but there are signals saying that it is a possibility, and we need to then keep a lookout and monitor very carefully those who we think are at risk of suicide. So we are seeing in a number of ways an increase in activity levels. And what's also happened is that during the peak of the pandemic, when the nation went into lockdown and we had to very quickly adapt ourselves to, say, remote working and social distancing measures, several people were also not very sure whether to seek help, or they were anxious about coming to hospitals and attend appointments. So due to a combination of reasons, people who did need mental health services during the peak were not able to get the help they needed, although services were running, perhaps not at the same capacity. So we now have a combination of addressing the needs of those people who did not get the help they required during the pandemic, the exacerbation of existing conditions, new people coming forward, and an increase in the general prevalence or incidence of mental health problems. And we know that there are a variety of reasons why there might be an increase. We know that the pressures of lockdown and what it might have done in terms of lack of economic security, job security, the financial hardships, the change in relationships and the way people had to live together, not being able to access your social networks, the anxiety around attending work, schooling. I mean, in the UK, we are having similar conversations about how do we get the balance right between getting children and young people back to school and protecting them from COVID infections, because we know that there are some numbers which indicate rising cases of COVID in younger people. So there is that balance to be struck. And so a variety of reasons why people might be at greater risk of developing mental health problems, or more people might need help with mental health conditions. And so there's a mismatch between the demand and the capacity. So the demand is rising. The capacity has been affected due to staff being ill, social distancing, and having to accordingly modify the way we deliver services. So
what about, I'm sorry to interrupt you, what about online stuff? Like, here we have Talkspace, I think is the one, Michael Phelps is the Olympic swimmer. He sort of talked that up, but there are actually telehealth. I mean, we've all had to embrace that, right? So is that something that you think is the capacity there to increase telehealth for people, or an app? Because almost everybody has a phone, right? Usually everybody has a smartphone. And what are you seeing in Britain with that, related to that?
Yeah, I mean, apps are not used universally. I mean, I know that there are some apps being used in primary care, what we call GP services. But in terms of specialist services being delivered in hospitals or in specialist community places, we have adapted to remote working. So a lot of online, whether it's Microsoft Teams, whether it is Q Health, whether it is something called Accurex, Attend Anywhere. So we've got a variety of programs which allow us to do assessments and also deliver some treatments, that is, whether it is therapies or review of medications or whatever it is online, both audio and video. So that's been adapted very well, actually. A very good agile adaptation in GPs and primary care, and a lot of work goes on remotely or through the audio and video platforms, and a lot of it happening in mental health settings as well. But I think the issue is about not having blanket approaches. It becomes hard when you say that's the only thing available, or we can't do face-to-face. So I think it's more about getting the balance right. What we did in mental health, for example, is 24/7 helplines went up in many services. We expanded our existing, what we call crisis and home treatment teams. So a variety of services went, the ones which would normally have been maybe within working hours actually went 24/7, including all the helplines, and a lot of audio and video remote consultations. But we still need to be aware that there are some populations or some groups for whom face-to-face appointment is required. And when we're talking of children and young people, we know that it's really hard for some young people to have those remote consultations, and for some where remote consultations have worked well. So it's getting the balance right, I think, and not having any blanket approaches. But we've adapted to online working in a big way, where possible.
So thank you. I think that that's really very important. I think talking about communities where maybe the access to technology is not there is really important. It's something Marina and I have talked about over the past few months, actually. We have viewers watching from all over and watching in all age groups. So we have Allie Dreyer checked in, and she's on the pre-med track. We have Mickey Price, who is a top ENT surgeon in Brooklyn. We have Sonia Dutt checked in from Bermuda. We have Uma Koduri saying it's a nice and informative show. Thank you. I think so too. Somia's got small children. Leanda Delp likes the show. So I think we have people who have interest in everything we're talking about across the age spectrum. And I'm wondering, one of the questions I get asked as a surgeon, particularly by parents of small children, is what is the risk in terms of their child's developing brain when we talk about giving them anesthesia? We know some papers came out about that, and I wonder if you can talk to what pediatric anesthesiologists are doing to minimize any long-lasting sequelae if your child needs surgery.
Yeah, so there is it's not a misnomer. There are studies in rats. They have studied about the cell damage with the exposure to anesthesia. So experimentally, it is proven that anesthesia can cause damage to the brain cells. But in humans, we have not had any single study which said that anesthesia is detrimental to the brain or causing brain damage in children or causing any developmental delays and so and so. So there are studies going on, but we do not have any studies which have proven that anesthesia is harmful to the children. Some of the parents, they do get a lot of information on Google. They study, they come with, they ask me these questions. Does anesthesia cause damage to their child, any learning disabilities? I had kids who come, they are frequent flyers. They come very often for procedures like oncology procedures and all. We do anesthesia almost every week to some kids. And we have not seen anything like that, any delays in school or anything. These are oncology kids who come for a lumbar puncture. We do anesthesia for those kids. And some dressing changes some kids have, they come frequently. And we ask the parents, nothing like that. So I mean, evidence-based, we have not seen anything. Studies-wise, we have not proven anything that anesthesia causes this damage to the cells. But rat studies, experimental studies have proven. So I think we need more data to say that, hey, anesthesia can cause damage to children or can cause learning disabilities. I had one mom who said, please do not do anesthesia. These are the anesthesia gases we use for children, sevoflurane and all these. So the mom said, please do not use any of that. Just give me only IV stuff. They can demand us to do so and so. So we honor those parents when they come up with certain things in their mind. We try to explain them, but no, I don't want any anesthesia on my kid, just do sedation. So we modify the techniques and do whatever is comfortable to the parents because we explain them all the risks and all. We also see in the anesthesia consent right now, which is a new added thing. Anesthesia can cause brain damage and all that stuff. We do have those things written already in the consent. Yes.
Well, it's scary. My son underwent. I'll tell you what. He had to have general anesthesia. He got a baseball to the nose, so they had to do a closed reduction. And my friends were there, so they regaled me with the details. I was ready to vomit. I was like, "Wait, you were laying on my son's nose, trying to straighten it out. I don't want to know that." But I will say, it did not affect his brain. He's done exceedingly well for himself, and. But it is a concern when you see these reports, and it's always nice to find ways to mitigate how we treat the kids to try and minimize. But, giving them totally IV sedation with like propofol can also have a brain effect. But I understand that you're trying to address, the concerns of the parents. Ananta, I hear that you have a blog. Can we talk about that? You're like, oh yes, I'm the president of the British Indian Psychiatric Association, and I'm blogging. Like, I have a blog that I haven't put anything on in like since 2011 or 2014. So it's time, and let's talk about this. You did something for South Asian history or something. Can we talk about?
Yes, I mean, I'm not a regular blogger. I have to say, I took a leap for the first time when I wrote for this South Asian History Month. So actually, it was a very welcome thing to see our Royal College of Psychiatrists held a month-long celebration and marking of South Asian history for the first time. And it was an opportunity for many people, members of the college and others, to talk about their experiences as South British Asians, the two cultures that they live in. And I have tried to explain similarly about the dualism that I experience as a British Indian, and how, there are times when I have had very negative experiences over the years, but I have been able to deal with those because of the kindness and the very positive influences and mentors that I've had over the years as well. So I've tried to capture that in a blog. And in the UK as well, we've had South Asian Heritage Month going on, and it's the first time ever. So it's a real opportunity. I think part of addressing the discrimination and the racism and everything else that we have been talking about in the wake of COVID and the brutal killing of George Floyd is we need to be able to talk openly about our cultures, own it in an authentic way, be able to be fully ourselves, and own the various aspects of our culture. And I've been shaped both by my Britishness and Indianness. And as I've said there, I think of it as having two motherlands, an adoptive and a birth one, so that it helps me to blend my two identities and make the most of it rather than having to struggle. It has that confidence has come over the years. It's not happened easily, but now I feel a bit more able. But I know that there are many, many people, both in the workplace and in society, where it's not easy for them to be their full authentic selves, where they don't feel accepted that way, and where they face a lot of discrimination at individual level and racism at an institutional or structural level. But it's by sharing stories, speaking out, standing up for others, advocating, and looking at it as an important issue that we can start shifting these narratives a bit and bringing about something more positive. Just on that note, I want to say it was very fascinating to hear from Dr. Gotimukula about the American Association of Physicians of Indian Origin. And we have in something here called BAPIO, which is the British Association of Physicians of Indian Origin. And both BIPA and BAPIO are going to be celebrating 25 years next year in 2021. Wow. And wonderful. So it's very fascinating to listen to your account, look at the journey, and I hope we can collaborate, to share stories, further along the line. But these networks are very important as well. So yes, please read the blog if you can. There are various other blogs which are on the website, and it's my first attempt at a blog. So
all right, well, we will definitely read it, and maybe we can travel by then and we can all celebrate your silver jubilee in person. Anupama, I loved when I asked you for a headshot. You sent the most gorgeous picture in a Dharmavaram silk sire and a Pontuva bindi. And I thought, wow, this woman has it all together. And maybe you can talk, I know we only have about 8 minutes left in the show, but maybe you can talk about bridging that divide, as Ananta talked about, between our two motherlands, and even within being Indian. I grew up in America since I was 5, and when I would meet an Indian person, they'd start talking to me in Hindi, and I don't speak Hindi. I'm from Bangalore, so I speak Kannada. So I think there's humans, and I hate to say this in front of a psychiatrist, humans divide ourselves in so many little pieces, right? And so I literally, as I grew up in Flushing, Queens, would be asked at parties, oh, why don't you speak your mother tongue? And I'm like, I do. My mother tongue is Kannada. So I think navigating our way outside of India and within our Indian friends. And I think I just wanted to show you guys this. This is an amazing resource called the COVID-19 Health Literacy Project. And the map on the left shows the major languages in the various parts of India. And the graphic on the right shows the Health Literacy Project, which has published the same information about COVID in over 30 languages. Between the four of the women on this show, we speak or understand, of course, English, and then several Indian languages, including Malayalam, Telugu, Gujarati, Marathi, Hindi, Tamil, and Kannada, as well as Spanish. And of that list that I said, only Kannada, my language, is not covered by this project. And I think this is an amazing resource to share with our patients. So it's at COVID-19 Health Literacy Project.com. And I think it's amazing. So I wonder, Anupama, if you can talk a little bit about your journey bridging the gap.
That's amazing to see that. And I think I will go back and look at that website. So bridging both the countries, right? I'm born in India and I moved here in year 2000. I did anesthesia back in India and I came here. I wanted to do pediatric anesthesia. That's my passion. So I moved here. We didn't have any pediatric specialty in anesthesia back in India in 2000 years. So I moved here, I did residency, and personally, I wanted to pediatric anesthesia. That's how I got trained in. And I've been working for the last 13 years. So, and then my thinking is, I think as an Indian, but I'm here, I'm already a citizen of United States. So I'm kind of, I have both actually. So motherland and the karma bhumi, janma bhumi, we say, right? that's where we are. So how I got into API, and API is an association. It represents the entire Indian origin physicians. So we have physicians from all over India, but we have this diversity, but we are one voice, one organization, and we are very strong. And it's a powerhouse. I would say it's a powerhouse. We can do a lot through this association. That's what I was passionate when I heard about it. And here I am being an incoming president of AAPI. So let me talk a little bit about AAPI here, since I have this opportunity to talk to the community. So we have several, in our mission statement, we mentioned that we have educational, we have cultural, we have philanthropic and networking opportunities and all. So AAPI has 135 chapters, which include from all states of from all the states. And also we have specialty alumni chapters. So we network through these chapters throughout the country, and we try to do the projects all over US through these chapters help. So we have several projects we have been working on and we are working on. And a few years ago, we started this childhood obesity. You know how the obesity problem in the United States is. So we had that and we spread out to the entire country. And we had that, and now we are working on hypertension and diabetes projects, and we have several research projects in working right now. We encourage all the medical students, undergraduate students to volunteer, come forward, participate in these research studies. And Dr. Sabita Balaraman is one of the Michigan doctors, and she is the committee chair. She's working on these projects. So awareness projects we are very much interested in. And also the COVID time, API has done, I have to explain this. Give me 2 minutes for that. So during the COVID time, this organization was the first organization who said we have to have universal masking. We have to have the isolation, we say lockdown, but it's called shelter in place. So we are the first ones to write to Trump, the president, and also to the HHS, and all the letters were written how we can control this pandemic. And interestingly, it's going well, what we thought, like testing kids should be like a pregnancy test. It should be available. So we are getting there slowly. It's taking time. And we have conducted several webinars for our physician educational, and we did COVID fundraising, and we helped with the PPE masks all over the country, and also we had honored the nurses all over the country for their great service they are doing during this COVID time. And so and so activities are being planned. So I'm more interested in mission, actually. Mission, these are the doctors, the powerhouse of doctors, so we have so much of resources. So I wanted to do the mission work in different countries, so we've been planning a few next year to go and serve the needy population across the globe. The other thing is the educational part of it. We are trying to bridge Indian medical students, and here we want to promote education, anything exchange knowledge and guidelines and everything between these two countries. There we are working with the students and faculties in India, and so that we can exchange, and also with the government, healthcare government in India as well. We meet them every year through our Global Health Summit.
My goodness, Anupama, you have like such a
I can go on and on. So I'll stop here.
But I have to say, what we're hearing from both of these amazing women and their organizations is that they may have Indian in their name, but they are really dedicated to the health and welfare of all of the people in the countries that they serve and in the world that they serve. And I find that really empowering at a time during this COVID pandemic when we all need some good news. This is wonderful news. And thank you, Nina Yoshpe, who's an ENT from California, who's watching. She says the show is terrific, and it's terrific because of our guests. We unfortunately have to say goodbye to them. Ananta Dave is a child and adolescent psychiatrist and the president of the British Indian Psychiatric Association. Dr. Anupama Yeluru Gotimukula is the president-elect of the American Association of Physicians of Indian Origin, and she's a pediatric anesthesiologist in San Antonio, Texas. Thank you, ladies, so much for joining us and for sharing your wisdom and your compassion with us and our viewers.
Yep. And those of you guys watching, if you like the show, definitely like, share, invite your friends to watch. You can see that at She's on Call on YouTube, Twitter, and Facebook. And I want to thank our producers for the show. There's been active tweeting going on, and just overall, the quality of the show is really due to our producers and the behind the scenes work. And then stay tuned for next week, because we have Dr. Doris Day joining us. She's a dermatologist. We're going to talk to her about mask knee. You didn't know it was a thing, but it is. And then also Dr. Valerie Fitzhugh is joining us. She's a pathologist. Both of those doctors do have some overlap, but you can follow them on their Twitter feeds. They're quite prolific in social media and good people to follow. So stay tuned. And Suju, I'm going to say bye to you for this week. And
thank you, ladies. Bye-bye. So nice to see you. It's so nice to meet you both.
Thank you.
Thank you very much for the opportunity.
Bye, guys. Stay safe. Wear a mask.